Thank you for introducing me, and I would also like to thank the organizers for giving me the opportunity to present the work that we are doing within our laboratory. So I am at the moment an associate professor within the Department of Clinical Chemistry and Laboratory Medicine at the Leiden University Medical Center, and I'm heading mostly the research and development team of this unit, which is kind of split between two major tasks or major things that we do. One is the development of novel tests, where we really try to advance laboratory medicine through novel biomarkers and novel targets. But on the other hand, we also spend quite a lot of time on aiming for global standardization. And today I would like to present basically where these two come together. So I really appreciate being here, and I really appreciate being able also to speak to you. So like I said, like the title of my presentation, I'm going to speak about personalized medicine for improved patient care, and specifically the role of mass spectrometry-based precision diagnostics with a focus on coagulation. An overview of my talk is that I would like to first give a little bit of an introduction of metrology in clinical chemistry and how it is organized, then go towards precision medicine and the role of proteins and metrology. So what really, within our laboratory, within our clinical chemistry laboratory, we aim to add a value to healthcare through clinically effective medical tests. And what we basically do is that more or less any of the bodily fluids that are that you can basically take from an individual, we measure compounds in these, and we try to aid in diagnosis. And approximately 70% of the medical decisions that are being made, not only in a hospital, but generally I would say, is guided by clinical chemistry tests. Within 1 hour, clinical test results may provide life-saving information. There are now, for instance, pilots running where we even within the ambulance are already measuring troponins, and we're trying to triage whether an individual actually has to come to the hospital for cardiac, basically for heart attacks, or whether the results are in such a way that it isn't necessary. So there really are quite a lot of medical implications that are depending on the medical tests that we perform. So the aim of standardization of medical tests is to provide consistent results no matter what position in time and space. So basically, if I go to a hospital here in Paris, I would like to get the same result as whether I go to a hospital in the Netherlands. And specifically, this is prerequisite to have global decision limits. So basically, we should be able to to define decision limit and use them globally, to also have global reference values and to have global treatment targets. And why I think this is very important is because doing these studies to define decision limits, reference values, and specifically also treatment targets, these are very costly randomized controlled trials most of the time. So there is a lot of money that is involved, and it would be really a pity if we would have to redo this all over again for every, say, manufacturer of a test again. So in clinical chemistry, the standardization starts with the availability of a complete metrological traceability chain, which is described in ISO 17511. And I think that you are quite aware of these metrological traceability chains. But what I think is rather important is that there is on top here, it's mostly metrology institutes that are kind of providing the top of the traceability chain. Then we generally have a layer of IVD manufacturers who use this top of the metrology chain to calibrate. And the lowest part, actually here at the bottom, is where the medical laboratories find their place and where they actually apply those kits that are brought on the market by the IVD industry. So standardization of clinical tests is generally, I would say, influenced or maybe even in part decided by the International Federation of Clinical Chemistry and Laboratory Medicine, and their mission is to advance the science of clinical chemistry and to apply it to the practice of clinical laboratory medicine. And I think what is really important is that they are generally governors of what type of standardization projects are initiated. Currently, they have an executive committee, 6 team-oriented committees, and 20 working groups, and these are task-oriented, and mostly within working groups, that is where the standardization projects are actually taking place. So, what the IFCC does, and I'm going to just get everything in, is how do they decide on what type of projects to actually do? They either do horizon scanning, where they say, okay, what is important for us to do, and there's also what they call third-party approach, where people can actually ask them and say, okay, we have a proposal for this and that, and we think that it's necessary to start a standardization project on this. What I think is important to mention here is that there is the IFCC scientific division, who decides more or less eventually on whether a working group is being established. But once the decision is made, you also have to fill basically your working group. And typically working groups comprise of national metrology institutes, academia like me, I'm also involved in one of the working groups, IVD industry, who are also very important because of course they're an important link basically in the complete chain, as well as research institutes. So this is really where the work is being done, where the standardization takes place. And once there is a reference measurement system, so this whole unbroken chain of procedures and calibrators, you can submit this top of the traceability to the JCTLM, which is a Joint Committee for Traceability in Laboratory Medicine. Basically, it's a combination of, amongst others, the BIPM and the IFCC. And here, basically, there is a worldwide database of reference materials and reference measurement procedures that are in place. So that is how it works. Then we come to our current healthcare system, or should we actually call it healthcare system. Here I show you a graph of, and I do admit that it's a slightly older picture, but I think that the situation has not changed too dramatically over the time. Here I show you a graph, and what you can see is that for every drug that's on the market, for some people it is very effective, but for most of the individuals it is really not that effective. So most of the therapies really are effective only for a small subset of patients. And part of the reason for this is that we do not completely understand the underlying causes of the diseases, but also how basically the diseases progress. So we really actually need to have better diagnostics. And this is represented in this slide, where currently we basically have one drug that more or less fits all, and that was really the approach that I was showing you on the previous page. But what we really want to go to is to have the right drug for the right patient at the right time and in the right dose. And this basically requires us to have much more precise diagnostics and also much more precise diagnostic tests. Now, that is not to mention that we really need to have more precision in terms of what is the actual value. That is also important. But what is, I think, most important is that we actually target the biochemicals that are most clinically relevant. So that was also something that was recognized by a working group on test evaluation, headed by Rita Horvath from Australia. And she designed, or with her working group, a framework for test development. And I think what you have to appreciate in this, and what we always say is very important, is that we need to have this clinical pathway in the middle of everything that we do. We always want to ensure that what we do is clinically relevant and that it will actually benefit patients. So the first thing when we start developing a new test, or when we think of a test, is that the measurand, so the actual compound that we intend to measure, of a clinical chemistry test should reflect the clinical problem. So does it really add information on the clinical problem? Then when we start developing a test for this, the analytical performance should really be in line with the required clinical performance. And of course, the analytical performance is also where the standardization comes in. So currently, my line of research is related to proteins, and also my presentation will be focusing on proteins. But most of the clinical chemistry tests focusing on proteins at the moment are based on the principle that on the one gene, one enzyme, or the one gene, one protein principle. And that was something that we thought of in the early 1940s, when basically, we just saw we could identify individual proteins. However, we now know that this is no longer the case, because an individual human gene can actually be modified either at the genetic level or at the protein level. And through these modifications, you can actually have a large variety of proteins originating from an individual gene. And these subsets, or these variants actually, we call proteoforms. And this is something that makes the world of protein biochemistry, I would say, a lot more complex than we envisioned in the 1940s. But I do think that, and I actually know, that these proteoforms are very important when it comes to diagnostics. And I will provide you an example in the coming slides. Moving on to antithrombin, which is my protein that I worked on from the beginning. I have a background in analytical mass spectrometry, and particularly I was looking during my PhD in protein glycosylation. And I didn't really know how to bring this basically to a patient until I moved to the clinical chemistry department. And there I said, okay, I want to have a model protein that actually has glycosylation, but not only that as interest. So what is antithrombin? It is a 58 kilodalton glycoprotein, which has an essential role in the coagulation cascade. It causes a lack of functional antithrombin deficiency, or a lack of antithrombin deficiency leads to an increased risk for venous thromboembolism, so for thrombosis. This can either be caused by a decreased concentration of antithrombin, or it can also be caused by a dysfunctional antithrombin. And this dysfunctional antithrombin can be caused either by genetic variants or by altered glycosylation. So the current diagnostic pathway for antithrombin deficiency is that there is a suspicion of antithrombin deficiency, then an antithrombin activity test is being done, and, well, guess what? The units of the antithrombin activity tests are IU. Basically, it is a percentage. We have no idea how much it is or how much it isn't. And generally, we say if it's over 80% it's healthy, and if it's below 80%, well, you could do an antithrombin antigen test, but most of the time, at least in the Netherlands, this is not something that's being done. In other countries, people are a little bit more rigorous in really assessing what is going on. We thought that actually this is all very nice, but when you look at the activity that is actually being measured, we think that this is a combination of the concentration of the antithrombin as well as the molecular characteristics of the antithrombin. And we said, well, both the concentration and the molecular characteristics are something that we can assess using mass spectrometry, which is why we set out to develop a test for antithrombin. Well, of course, there is a mismatch between just there has to be a real clinical problem when you start developing a test. And in the case of the antithrombin test, this is really the case, because the activity test only provides a rather vague picture of what is actually going on. For instance, if you would look at this picture here on the left-hand side, you would probably think that it is a girl with the pearl earring that you have here. However, in reality, it may actually not be the girl with the pearl earring. It may be something completely different. So this is what we really wanted to uncover and what we wanted to provide our clinicians when we started this project on the test. What I do want to mention as well is that currently there is a relatively poor diagnosis, and typically the poor diagnosis results in a poor healthcare. often, basically, you have biological and pathological diversity, for instance, for antithrombin. Then you have the guidelines that doctors are typically referring to and that they are acting on. And because there is quite a lot of variation in the antithrombin screening test, there is quite a large difference, particularly when it comes to the identification of antithrombin deficiency. The results are often not very clear, and what that actually causes is that one, the screening guidelines are basically saying there is insufficient evidence. But the second thing is also that the therapies are a one-size-fits-all approach, because basically we just don't really know what's underneath. We just know that there may be a difference or a decreased activity, but we really don't know what's going on. And it could very well be that a different mutation in one part of antithrombin has a completely different clinical phenotype than an antithrombin deficiency caused, for instance, by glycosylation deficiency. So we really think that we have to dive deeper and we have to get a better grasp of what is going on. So when we set out, we wanted to do a molecular characterization through the monitoring of peptides. So what we do, we chop our protein of interest up in peptides through proteolytic enzymes, and then we actually measure these peptides. What we wanted to do was get basically three types of information. One, quantitative information. Two, information on the mutations. And three, information on the glycosylation of the antithrombin in the patient. So we have a method, and I do not want you to completely understand all of this, where we first capture the protein from citrate plasma. And then we do what is called the bottom-up mass spectrometry approach, where we digest the protein of the antithrombin in the presence of stable isotope labeled peptides, and we actually measure each of these peptides. And if there is a difference in the signal for one of these peptides, we know that there actually has something has changed in this peptide, and that there most likely will be the deficiency. I'm going to skip this. So we actually performed analytical validation of this test, and we assessed the precision, linearity, carryover, all kinds of things that we are obliged to do, basically, and then started to apply our test. And the first thing was, okay, there was a clinician who came to us and he said, yeah, I have this patient, and she is deficient, borderline for us. Actually, here you can see that for all of the more general tests, I would say, there is no deficiency, but for antithrombin, there was constantly this value between 96 and 72, and he said, this is something that is borderline, I don't really know what to do with this. She doesn't really have too many clinical symptoms, but I really don't know. So we said, okay, let's see if we can actually pick up something and if we see something. And we initially weren't very, we didn't think too much of it, we didn't expect much. But when we actually did the measurements, we measured initially 2 peptides, which are the ones here on the left-hand side. And what you can see, where's my pointer? Oh, there. What you can see immediately is that for this peptide LVSAN on the left-hand side, the values that we obtained here, but also the concentrations that we obtained here, were actually within the reference limit. But when we assessed also other peptides, we saw that there was one peptide that had about half the concentration that was expected, and it was outside of the reference range. And then we thought, okay, most likely this is where there is a deficiency, and then we actually looked into literature for what type of deficiencies we would expect, and we were also able to actually measure the affected peptide, which you can see most on the right-hand side of the graph. So we were actually very happy, and we thought, yay, we can do this. So then we actually moved on to larger cohorts, and we first assessed quantitative defects, where we basically just look at the concentration. I have to tell you that we are actually measuring in molar units, and the reason that we're measuring in molar units is because we measure these small peptides, and they basically just refer to the number of the antithrombin proteins in a sample rather than grams per liter, because when you have glycosylation, your actually molecular weight of the protein changes. So you cannot unambiguously define the molecular weight of antithrombin and of most of the proteins. We use molar units for this. So basically we were able to identify all of the quantitative defects, and then went on to also identify qualitative defects, where we were actually able to identify this in so far, well actually now more, but at that time 34 samples to carry variant peptides. We also specifically tried to make these variant peptides visible in our mass spectrometer, and we were able to do that for most of the cases as well. So then we said, okay, we have to compare our mass spectrometry test to the classic diagnostics. And what you may appreciate is that here on the left-hand side, you see the activity tests, and in general, there is about 81% that is of these individuals that was classified correctly. But when we use our mass spectrometry test, we were able to identify 100%. And this is even more profound for the type 2, what they call antithrombin deficient individuals, where you really have a defect. So not a quantitative defect, but a qualitative defect. There, our mass spectrometry test really outperforms. So, of course, it is imperative that we have to basically aid the clinicians. So we kind of started to draw up a clinical pathway for this, and on the left-hand side you can see the traditional diagnostics, and on the right-hand side you see the precision diagnostics. And what we think is very important is that there is this gray zone, which is typically between 60 and 80%, where clinicians often don't know exactly what is going on, and they basically, they feel like they are somewhat guessing. And particularly for this area, which is a gray zone, we think that we could add benefit using our mass spectrometry test. Specifically because, of course, not every clinical laboratory, or maybe, of course, at least for us, of course, not every clinical laboratory has the capabilities of doing mass spectrometry. So we think that we can be, for instance, a center of excellence, and then we can move on from that. What I think that is also imperative is that we want to not only use this test for diagnostics, but eventually also want to move on into protein standardization, because I do think that mass spectrometry is the method of choice for standardization, given that you can actually identify your compound of interest at the molecular level, rather than having a more broader, vague definition based on either immunoassays or, in the case of antithrombin, even activity. So these proteoforms, they're not just recognized by us. There are quite a lot of, well, not quite a lot, but there are quite some other groups that have now started to do research into the use of proteoforms for laboratory medicine. One of them is, for instance, the GFAP, but also IGF-1, and there are quite a lot of others. HbA1c is another one, where looking into proteoforms really is going to, we at least think that it's going to enhance our diagnostic potential. What I do want to mention, like I said, our research is not only based on developing novel clinical chemistry tests, but partially is also related to metrology and standardization. And I'm also part of the ProMed team, where we basically now aim to define or investigate what the influence of these proteostructures and also specifically the proteoforms is on the measurements and also on their function, and so what type of proteoforms we should consider when we really look into standardization projects for proteins. So with that, I come to my conclusions, and I think that I hope that I have convinced you that proteoform measurement is a really promising area for clinical chemistry. We can analyze proteoforms in a direct manner by mass spectrometry, and they can provide the right drug for the right patient, hopefully also at the right time. And it is important to standardize these tests, ideally upfront or at the moment that tests are being developed, to also enable standardized cutoff values or comparable cutoff values, reference values, as well as therapeutic targets. And I think that the current efforts that are going on in protein standardization are already not relatively complicated, and generally they don't even consider the proteoform. So this is really something that I think, we will have to up our game still in order to make this happen. Thank you.